Well, welcome all of you today. We're going to have an exciting call, and I wanted to just alert you to a few things. One, Bacon's going to post the link to an evaluation of today in chat, and we learn a whole lot from you. So I know some of you have to drop off a bit early, so if you could capture that link and give us your feedback, that would be most appreciated. Also, just a kind of a preview, the topic calls that are in planning stages that will be coming up in the next few months on the second Thursday of every month are one is about legal wins and realities regarding healthcare, rationing and visitation. Another is what does it take to help people with disabilities put together a quality and real personal preparedness plan? A third one is going to be about homelessness and disability and discussion about room key to home key, COVID-19 issues, cooling and warming centers, personal assistance, and IHSS, all within the COVID environment. And where are we? We're also looking at some issues around long-term recovery and about effective and efficient use of social media before, during, and after emergencies. So we welcome your input for more ideas as to future calls. So today we have a really exciting and very relevant panel related to preparing for hospitalization, practice tools and solutions for people with disabilities in atypical times. The atypical times kind of being an understatement for what's going on here right now. So feel free to post your questions in Zoom, in chat, sorry, and we will have a good hour or so to have a good discussion after the presentation. So, but feel free to post your questions as they occur to you. If that's not comfortable for you, we will also be taking questions by you raising your hands, and you do that through the participant list. There's a hand raising icon, and we'll keep an eye on that as well. So I will turn the panel over to, we'll turn the presentation over to, let me see, Sarah, you're first. Is that right?
That is correct. Thank you, June.
Okay.
Great. I think we will start by doing a quick round of introductions from all three of us, and then we'll jump right into the presentation. But my name is Sarah Marshall, and I'm a speech-language pathologist in Madison, Wisconsin. So for those of you who jumped on after the weather talk, it is cold here today. It's the afternoon, and we are expecting snow. But I do provide some inpatient consultations, but my primary role is a speech-language pathologist in an outpatient clinic that works with individuals of all ages who use augmentative and alternative communication, or AAC. And so my portion of the presentation today will be talking about how to prepare for a hospitalization and all of the work we do before we get there, in hopes that we don't, but so we know that we are ready in case that happens. Karen?
Hi, my name is Karen Turner, and I work at Mass General Hospital. I'm a patient navigator for people with autism and developmental disabilities, and I have a background as an occupational therapist. My role here at Mass General Hospital is really just to help people with developmental disabilities access their health care, so I can support them in any locations in which they're here, whether it be in the emergency department, inpatient, coming for a surgery, etc. So I've been involved here at MGH, but also larger within our system and somewhat across some hospitals across the state too, just to think about how we make sure that individuals with autism and developmental disabilities, which then translates to other disabilities too, are able to access the healthcare that they need during this time. And I'll turn it over to my longtime colleague here at MGH, Rachel.
Hi, everybody. My name is Rachel Tobin. I'm an inpatient speech language pathologist at Massachusetts General Hospital. We're in Boston, Massachusetts. And I completely do inpatient care. So I see patients when they're in the hospital on our neurology units, trauma surgical, general medicine units for speech, language, and swallowing evaluations. Also, under our umbrella, are doing evaluations for AAC, as Sarah had mentioned before, and hoping to sort of improve patient-provider communication for our patients who have complex communication needs. And I'm very happy to be here with you today.
Great. And Megan, would you be able to share the slideshow, please? Thank you. Great. And as June said, our title of our presentation is Preparing for Hospitalization, Practical Tools and Solutions for People with Disabilities in Atypical Times. And as June stated, we sure are living in an atypical time. I can advance the slide. Alrighty. So we have about an hour and a half together. Karen, Rachel, and I hope to deliver our presentation in about 30 minutes and allow an hour for discussion and Q&A. So we are excited to talk with you all more at the end of the presentation. Our objectives today are to discuss and describe tools and strategies to help prepare for a hospitalization, increase our awareness of regulatory standards that support communication access when you are in a hospital setting, and then describe the tools and strategies you could use if you do find yourself or somebody you work with hospitalized. Next slide. Alrighty, so I'm going to get started talking about that proactive planning and why it matters. Almost the entirety of my presentation is referencing Sarah Blackstone and Harvey Pressman's 2016 article, and I think I saw Sarah on the call. The reference for that article is at the end of the presentation, and if this is something you're interested in, I would encourage you to read the entirety of the article. It's really excellent information. But what we know, individuals with complex communication needs are at increased risk for communication breakdowns. Why is that? First, there's a difficulty with communication. And then the other areas that we're going to focus on more so today, that there's often limited preparation. And then there can be poor hospital staff awareness. It's important to address this because when we're better prepared, that leads to better outcomes. And something I want to mention as well is that people are facing communication breakdowns currently due to COVID-19 who did not have complex communication needs coming into the hospital. So we know that COVID-19 results in difficulties breathing and often requiring intubation. And so that could take somebody who may have a disability or not, baseline may be communicating verbally, but upon a hospitalization has a change in that ability. And so although I'm going to focus a lot on tools for AAC that people who have baseline communication impairments might be familiar with already, some of these tools and strategies are applicable to people who don't have those baseline impairments still to prepare in the event that what we hope doesn't happen does, and that we find ourselves hospitalized. Next slide. Alrighty, so the required steps for proactive planning is educating staff on the value of AAC and necessary approaches, and then preparing individuals with complex communication needs in advance. What we have time to focus on today is how to prepare. And so that's what we're going to jump into on the next slide. So what can we prepare? If this is an individual, or if you are an individual who has a communication device or system already, I would encourage including medical vocabulary right away. I work with pediatrics through adulthood, and we start instruction on health literacy very early, making sure that vocabulary is available and that instruction on how to use that vocabulary is provided. Some examples might be medication names and purposes, procedures that are frequent, daily cares and instructions on how to complete those. I have some individuals who actually have videos of how they prefer or require that their cares be provided directly within their communication device, so that when there is a change in staff or a new caregiver, the individual can be autonomous in providing that training. Of course, pain type, location, severity. And then next slide. Okay, another thing that Sarah and Harvey recommend is a medical passport. And this is a great tool for individuals who use augmentative and alternative communication, and even individuals who don't. And this is actually just like a paper card that you can keep on your person that's going to go with you. And when I think about what would be important to include on a medical passport, it's anything that you might be communicating verbally as you enter a hospital or an emergency room. Your personal information, your communication preferences, the need for an interpreter, any medical information that's really important, blood type, medications, allergies, your insurance information, and then contact information. Do you have an advocate or a power of attorney that the hospital should know about? And even like your primary care doctor. So on the next slide, I have a picture example of what this could look like. And there's a link there on the slide to this example, but if you just Google medical passport, there are hundreds of examples that you can get an idea of what might work best for you. Next slide. Okay, another recommendation is developing a grab and go bag. This doesn't have to be the physical bag, although it can be. It could be a backpack, it could be a wheelchair bag, or you could keep these, any of these applicable tools or strategies on a USB flash drive and ask somebody at the hospital to print them for you upon admission. But some ideas that could go into a grab and go bag, and I will have video or picture examples of these on future slides, include description of any communication strategies you might use. So maybe asking individuals to speak slowly or write down choices, maybe the technique of partner-assisted scanning, if that's applicable, and how the communication partners can really support you in being successful. Any health-related communication boards, particularly if you do not, or the individual does not already have a communication device or any communication boards, there are health-related boards available that I will show you today that you could print off and prepare. If the individual does have a baseline communication impairment and is using a communication device, you could take screenshots or use the desktop editing software to print off communication boards directly from the device and laminate those to have available. You may consider including a list of assistive technology, things like glasses, hearing aids, wheelchairs, anything that you might use, and be sure to list where it's kept and how to use it. So if somebody were to go to your home to find your glasses, they would know where to locate those. Of course, any of your legal information, power of attorney, advanced directives, wall signage, and we'll go through what that looks like in a minute, and an extra charger for any of the assistive technology that you do use that would need to be charged. Next slide. Okay, and here's an example of a communication board. This was developed specifically in response to COVID-19 by the Patient Provider Communication Task Force. And the link on the slide will take you directly to their website. There are a variety of boards with different grid sizes, some text-based, some picture-based, pediatric and adult, some for medical decision-making. And these are things that if your hospital isn't familiar with these boards, or doesn't have access to them, you could print them off ahead of time and bring them along with you. Next slide. And we talked a little bit earlier about communication partner instructions, and this is another example from the Patient Provider Communication website. And what you're seeing on the slide is an example of, or instructions for a communication partner of how to execute the communication strategy of partner-assisted scanning. So there's both written instructions and visual instructions to assist a communication partner in using a communication board that you may not be able to point to directly yourself. Next slide. And this is just another example of something you could prepare ahead of time. Many hospitals do have a version of a pain scale in hospital rooms, but it never hurts to bring your own, especially if you have a particular pain scale that you are successful using. This is an example of one that is free to download, again, from the patient provider website. Next slide. And here's an example of some wall signage that you could include, or even just picture representation of how you like things to be positioned or how you need things to be positioned for you. This particular individual used, you can see here, it's hard, there's a lot of black, but on the headrest of that wheelchair is a modular hose mount and then a small switch that the individual used by turning his head to the right to both control a communication device and a nurse call. In his grab and go bag were pictures of how that should be mounted to a wheelchair or a cardiac chair, as well as pictures of how it should be mounted to a bed. And so if there is particular positioning of either your body or your equipment, it never hurts to include those images as well. Next slide. And here's some more wall signage that I had mentioned. It might be important to indicate how you communicate yes and no, or even some basic advocacy that's so crucial. The sign here on your left with that red border, it reads, "Please talk directly with me to include me in my medical care plan. I am capable of my own decision making and would like to be involved in discussions surrounding my care." So really letting everybody who comes into that room know that I might not be speaking verbally, or I may have a physical disability, but I am my own power of attorney and I want to be making my decisions myself if that is the case. If there is a power of attorney present, you could put that information on the sign instead. Next slide. Okay, so you have all of these tools. How do you prepare to use them? Something that I do a lot in therapy with individuals is role playing. It's important, right? You don't learn to swim when you're drowning. It's important that we practice these tools in low stress settings when you're not sick, you're not stressed, you're not alone in a hospital. One thing though, as if you're a communication partner doing this role play, is to anticipate questions, needs, discussions, and decisions. And the best things you can do is really sabotage the communication interaction or practice a communication breakdown. So play that nurse who just can't understand what you're trying to say, and then provide the individual with a disability with support to learn how to repair that breakdown or maybe message another way. This is a really great tool, especially for children in teaching resiliency and communication and ways to identify when your partner might not understand and what we can do about that. And it's important to practice not just face-to-face communication, but how will non-face-to-face communication look? Will you still be able to access your cell phone or your email in bed? Or what type of mounting solutions or other tools might you need to be able to communicate with people who aren't present? Next slide. Okay, and then there's also some proactive planning that I would encourage you to consider with your hospital. If you know which hospital you'll be going to in the event of emergency, it could be helpful to call ahead of time and just ask some basic questions and perhaps have some documented in your chart. For example, you might want to describe or have documented your disability, any needed accommodations, communication methods, support staff and advocates, people to contact for help, any medical decision makers, things like that. And I see a question that I think is more applicable to address right away, if that's okay, June. The question was to please describe partner-assisted scanning in more detail. And I think I will just describe that while it's fresh in everyone's mind. If you could go back, actually, Megan, to the picture of just a communication board, I can kind of talk the audience through that. That one, perfect. So when we think of a communication board, we often think of the individual just pointing to it with their finger or their hand. But if somebody is weak or unable to use their arms or their fingers for another reason, it is possible to still use that communication board through a technique called partner-assisted scanning. And so really what we do first is the communicator, or the individual, we want to establish a clear yes and no response so we know that they can signal their message. And then the communication partner or caregiver would point to the first row. So that row that says suction, what's my status, call my family. They're going to point to that row and ask the communicator or the individual, is it in this row? And wait for the individual to signal yes or no. If they signal no, we would go to the next row. If they signal yes, now the communication partner can say, do you need suction? And wait for a response. Are you asking about your status? And wait for a response. And you're going to continue to go through each option, row by row, and then item by item until the individual indicates, yes, that's my choice, that's my message. Does that, I hope, answer the question? Okay. All right, Megan, sorry I'm putting you to work. Can you go back to where we were? I think it was questions to ask your hospital. Perfect. So some additional questions you could ask prior to a hospitalization would be, how will staff be notified of my communication method? Is it documented in my chart, or will I need to bring a medical passport? Is there a patient advocacy or social work department, and how will they be notified when I arrive? What is the visitor policy, and is that different right now given COVID-19? Will staff be trained to support communication, and if so, how? And then will I have access to my personal AAC tools? And so if the individual is using a communication device already, can that come with? Does the hospital have its own? What does that look like? And then I think I have one more slide. An important one is what nurse call options are there. We know particularly when we're really weak, might be intubated, traditional nurse calls can be hard to access. So are there alternative options?
Oh, stop lying. Stop lying. I'm a $60 on you.
Can I post wall signage? We've discussed how that might be helpful, but are you allowed to put anything on the walls? Some hospitals might say no. Are there professionals with expertise in augmentative and alternative communication? And if so, how will they be notified that I'm inpatient? And I think with that, I'm actually going to turn it over to Rachel to start talking about what happens when you arrive.
Thank you, Sarah. That was an excellent review of the proactive measures that you can take prior to your hospitalization. It's really helpful, and we'll touch upon those sort of periodically as we go through the next few slides. I wanted to just sort of take a step back and tell you about sort of the perspective that we're coming from. So as we stated before, Sarah and I are speech language pathologists, and Karen has a background in occupational therapy, but works within our patient advocacy office. And we come from these larger teaching institutions, these larger hospitals. And while we don't know the exact systems that you guys, that the audience here typically interacts with, or the specific policies of your systems, the information and the strategies Karen and I will describe here, we are really hoping are general enough where you should be able to apply them to really any acute care hospital you might find yourself in. And another thing I want to bring to everyone's attention as we get rolling in this portion of the presentation is that healthcare providers are always doing the very best that they can. Do things always work out well? no. And I think that's just the reality. Please excuse the sirens. The office I'm in is right at the front of the hospital. Now, what I can certainly say is that all healthcare professionals really always do want to do the right thing, but they might not know what the right thing is for you. And within the context of COVID-19, they might actually have less time to figure that out. And so if you can come into a hospitalization prepared with these proactive measures that Sarah described, that can be so, so helpful to the healthcare providers. I know from personal experience when I've worked with patients who come in with a communication system and they say, this is what I need, this is what works for me. It is so wonderful to know that, hey, this patient has a strategy, a plan that works for them. And then we do our best to make that common knowledge for the healthcare team so that anyone who interacts with them can really implement that. So what I'm going to do now is move forward. Next slide, please. In talking about, sorry about that, my screen changed. I'm going to talk about just some regulatory supports that I think it would be valuable for you to be mindful of. There is an organization called the Joint Commission on Accreditation of Healthcare Organizations. It's more commonly called JCAHO or the Joint Commission. And this is an organization that evaluates healthcare organizations and really aims to inspire them to excel in providing safe and effective, high quality care. And they also have very specific standards of care. And one of the sections of their standards of care really focuses on supporting effective patient-provider communication. And so in this slide and the next slide, I've highlighted just a few sentences from those standards of care, just to really drive home to you that this is something that should be a standard of care in most in inpatient acute care hospitals. So you see here we have effective patient-provider communication is necessary for patient safety. Identifying the patient's oral and written communication need is essential. Next slide. The hospital effectively communicates with patients when providing care, treatment, and services, and communication needs may change during the course of care. So again, this just highlights that even though we all may be in different hospital systems, there may be smaller hospitals, larger hospitals, all hospitals should be striving for this standard of care, which is that we're really wanting patients to be able to effectively communicate with their care team. Next slide. Now, we're going to get sort of into the nitty-gritty now of strategies that we thought could be helpful when you are hospitalized. And Karen and I thought it was best just to begin right at the start of things when you arrive at the emergency department. And before I go into these bullets, I want to sort of highlight to people what an emergency department experience might be like. So emergency departments, for those of you who have been there, they are busy, they can be loud, there can be lots of beeps, and it's just a very busy environment. And I think during this pandemic that can be amplified. Some emergency departments and hospitals are working at capacity, and so arriving in an emergency department right now can be, it could be an overwhelming experience. And so for that reason, like I said before, going back to Sarah's proactive measures that she described, having those things in place are going to be really important when you're walking into an environment like that. So some things you can do right when you get to the ED are work with your nurse to ensure that your belongings are labeled and also documented in your chart. And that is especially important for things like a communication device that is your personal communication device and you're bringing to the hospital, hearing aids, glasses, anything like that. You want that labeled and documented. And everything okay? Also, making sure that you have those documents that Sarah had talked about. So power of attorney, signage, any sort of communication documents, either having your support person have them or you having them on your person, having those with you will be really valuable. Finally, thinking about that environment that you're in an emergency department. It could be quite loud. And if you are someone who would benefit from having a quiet space to improve your ability to communicate, and you find that you have oddly been positioned on a stretcher in a hall, ask your nurse if it's possible for you to get some sort of space that's a little bit more quiet and a little bit more private. It's always worth asking. Next slide. Okay, and so the next strategies I would highlight for you are to make sure that you share your documents with your doctor and your nurse and really explain their importance. In the ED, things are very fast-paced. And so sometimes taking that moment, whether it's you or your support person, to really explain their importance, that can drive home the point at the very beginning and be very useful throughout your stay in the ED or your admission. And finally, I would also ask about any other services that can be ordered by the physician right off the bat that could be helpful to you. This could be contacting the disability or advocacy office if you have that at your hospital, social work department, rehabilitation services that include physical therapy, occupational therapy, and speech therapy, and also chaplaincy. These services can be really good advocacy type departments for you while you're in the hospital. I think especially when maybe visitor policies can be a little restrictive, these are the kinds of healthcare professionals that could really be a benefit and sort of help you to reach out to your support people, your primary care physicians, and so on. And I'm going to pass the baton now to Karen, and she'll talk about the admission.
Thanks, Rachel. I just wanted to address, I saw June bring up a question, how wise is it to bring AAC and other devices like hearing aids, especially during these COVID times, and tablets, etc. I thought I would just address that really quickly too. I can completely understand how people would be very worried that those items could be lost. At the same time, I think anything that is going to help to improve your ability to communicate, but also your comfort as well, and making sure that you're not confused, that or don't feel confused, that things are clear to you, whether that be visually or auditorily, I think is very important. If you do develop COVID and you do require a hospitalization, some people with more severe forms of COVID can develop a condition called delirium, which really is just most characterized by confusion. And one of the things that's really most helpful when you're confused is to have your sensory, your other senses that are intact be as accurate as possible for you. And so, for example, having your hearing aids, having your glasses, having whatever you would use for communication, those things are very supportive to healing from having delirium too. So just wanted to kind of add that. I think the idea of making sure it's labeled, making sure that it's documented, that it's with you. Hospitals aren't required to replace devices if they're lost, but it's always important to, if you do have a lost device, to work with the hospital to see if it could be reimbursed for you, etc. Each hospital has different kind of policies around that. But at the same time, these proactive strategies of labeling, having it documented, and also planning to have a consistent place with where you want to keep it throughout the whole hospital. So if you have a bag that's always going to be with you, I know it was mentioned to bring an extra charger. If you have multiple devices, bringing your own charger and an extra charger is great, even just for having a singular device as well, so that if your device does need to be charged, it doesn't need to be removed very far from you in order to do that for you too. So just wanted to share those things and as things to think about when you think about what you want to bring with you. Rachel started us off with arriving to the emergency department, and I'm going to pick up with being admitted to a unit. And so some of the questions that you can ask, or that hopefully you have an answer to, the first one here when you're first admitted is, can my support person remain with me? Support persons are considered a reasonable accommodation, but I also know that visitor policies are, overseen by the hospitals and hospital systems. My experience and my best advice for you related to having a support person be with you is be very specific as far as the clinical ways a support person is going to help you and the staff taking care of you. So for example, with the individuals with autism that I work with, they may, many of them have a slower processing time in which they need more time to understand, or they have really specific words or language that needs to be used with them. And so, I and they and their support persons, we were able to make a case for, hey, in this very clinical context, in order to understand what you want them to do, like in order for, me to be able to tolerate wearing a mask, to be able to understand the steps of a procedure, I need my support person to help be my kind of translator in a way. And it goes not just for communication, but also, emotional support. You can make the same kind of arguments for, if you have a mental health condition in which your ability to communicate deteriorates significantly when you're under a lot of distress, you can again make that same kind of argument. But again, think about, the ways in which that support person can clinically improve care for you. And we can always talk about that more in our discussion if I'm not kind of being clear or giving good enough examples. This idea of wall signage, and I saw a comment come up that was really effective for one of the participants today in this Zoom. I've gotten a lot of feedback over my time here at Mass General, just how valuable those wall signs are, and or just signs that are visible, or information being highly visible to people. So if it's not on a wall, can it be on a door? Could it be on your bed rail? It doesn't necessarily have to be a door. Just could it hang on an IV pole? Just making it as visible as possible, because it's not just the nurse and the doctor that needs to know these things, but the personal care attendants who may come in to help you go to the bathroom, the people who bring in your meals 3 times a day, the people who come in to clean your room, all of those individuals and staff persons need to be aware of what your needs are. And so, on those signs, it can be about communication, but it could also be about how you want the room to be set up in a particular way, or the things that are most calming for you, like maybe having a warm cup of tea and having a warm blanket would just be highly comforting for you. Those are all things that you could consider putting on your own wall sign. And then finally, asking about alternative masks. So in particular, clear masks. I have an example to show you. This is, I took the strap off to modify another mask, but this is an example of a clear mask that is available for hospitals to have. And it's not an N95, so it's, it would not be able to be used in the context of a person who's COVID positive. But if you had a hospitalization for a different condition, and hopefully the hospital you have, sometimes these clear masks can make a really big difference for communication. So it always helps to ask about them. Please advance the slide. Then thinking about your team and the people on the team taking care of you, and also the plan for the day. I've had people that I work with just find it very helpful to ask if they could have a designated point person to communicate with. So is there one person on the team or one person on the unit? Maybe it's like a social worker, but maybe it's someone within nursing. The more consistent the person or the few people can be, the better. But just really so that you have one person that you can check in with on a regular basis, or who could check in with you, particularly if any concerns come up too. And then also, one of the strategies that we often share here with our nurses is, one of the first things of the day is just to walk into someone's room and, of course, introduce yourself, but also talk about what the plan is going to be for the day. And so always ask about that too. Hey, can you help me understand what's going to happen today? That would help me to feel more comfortable. And just make sure that however these plans are communicated to you, that they're communicated in ways that are going to be most supportive to you. So it may not be just verbally, but also having something written down, or a picture schedule, or things like that. I have some families that have prepared, like I'll show you an example of like different, this just goes back to the AAC idea, have prepared these are what are called Mayor Johnson symbols. They're just little pictures on like a clip here. And it's just, again, another alternative way to communicate. But if you're someone who really benefits from a picture schedule, it's these kinds of things that, you could think about going prepared with to a hospital. And common things that we do in the hospital every day: take medications, eat meals, etc. Question about, I see a question come up about medical grade masks. You're correct. Masks have different levels of protection. Just gonna make sure I'm answering. The masks that I just showed you, that is a medical grade. It's what's called an ASTM level 3. There's also that just means like protection from fluids and that sort of thing. It's not the same as an N95. So although this mask is this mask here is an ASTM level 3, it does not provide N95 protection. And so that's where any masks that we do have within a hospital do go through a process of vetting to make sure that they are safe. This one got emergency use authorization through the FDA too. So for example, here at Mass General, we only use FDA approved materials within the context of COVID. We are using any that are kind of emergency authorization used through the FDA. And so just wanted to share that about these clear masks. There are medical grade ones as well. And there are some coming out on hopefully that we're waiting for FDA approval. I'll show you one other really quick. This is another one that is one that we just trialed here that's made all of medical grade and FDA approved materials, but we're just waiting on the final FDA approval to then be able to order and use them. So just to know that there's lots of people out there working on the clear masks. There are also people working on N95 level clear masks. So hopefully that will be resolved soon, but I don't have any updates on kind of timelines of when those will be available. Next slide, please. Finally, like, how will everyone, this is another good question to ask, how will everyone taking care of me know what I need? I know I brought up this point already. I got a little ahead of myself. Are your documents visible for everyone to read and see? You can advance from here. Thank you, Megan. Ask if your medical record has an alert that indicates you have an accommodation need. So here within our the system of hospitals that Mass General is in, we have something called the special needs flag. It's a feature of a commonly used medical record system called Epic. And our process is hospital registration, when someone calls to either be a new patient or update their record, asks if that person would like to identify as having a disability, and then if so, what accommodations they would benefit from. And then the special needs flag has different categories that can be selected by the patient. So, cognitive impairment, physical mobility impairment, visual impairment, etc. That's just how this flag is kind of built at a basic level with EPIC. But what's great about this flag is then it is on the person's record. It appears right near where allergies are. It's viewable whether you're in our emergency department, you're in an office, you're in the inpatient unit. And it's a place where we can really highlight that an individual has a disability, wants to be self-identified in that way, and that also has an accommodation need. And so I'd strongly recommend reaching out to, your local hospital to find out if how they document disability, if there is a flag or some kind of alert in that way, and that then documents kind of what what really the most important, or what are the accommodations that you need in order to access your healthcare. I saw somebody bring up about the communicator. It's true, the communicator is the only FDA approved mask right now. There are a few with that emergency use authorization. The communicator is actually on back order right now, which makes that even more challenging. And that's where we're hoping the FDA will approve more masks, so that then that we'll have more available to be able to be ordered. I saw a question come up about one key hospital staff person to check in daily. How common are hospitalists, especially in smaller hospitals? Let's come back to this question, June, if that sounds good. I've only ever worked in at MGH in a large kind of urban hospital system. I have family that have been in smaller hospitals, and so I guess if you're questioning as far as like the hospital, I think I need some clarification around the question. So we'll come to that soon. Okay, we'll go ahead and forward from here. And then finally, we wanted to include a slide about addressing any challenges that come up. And so one of the most important things I can say, at least particularly coming from a patient advocacy standpoint, is to just say something immediately or as soon after the issue happens, so that a resolution can be worked on. Sometimes I think I've found some of the individuals that I work with, they understand people are really busy and they don't want to bother anybody. And but I just want you to know that it's very important to speak up, so that we can take the very best care of you, and that staff can really understand kind of what your needs are. Because in the end, that's going to be better for everyone, including the people taking care of you. If a challenge does come up, try communicating with that designated point person, whether it be a nurse, a physician on your team, a person on the unit, like a nurse leader. Don't hesitate to involve your supports from outside the hospital. Sometimes, having a peer-to-peer conversation, what I mean by that is like a physician or a specialist in touch with a physician on your team or a specialist on your team can make a difference for advocating for your kind of needs and perspective. And so just wanted to kind of share that advice. When there is an issue, remaining calm and being as clear and direct about it too. It's okay to just be very direct, with the language that you're using, but be persistent, don't feel like you have to let something go if it doesn't get addressed right away. It just means that there's still an issue in the little system around taking care of you that we can make better. And finally, also, when you do share your concerns with someone, sometimes then it takes time for concerns to be addressed. And that time can be very anxiety provoking for people. And so asking someone to explain what the next steps will be for. So let's say I don't have a solution for the problem yet, but I can at least tell you, okay, I'm going to speak with this person, and then I'm going to come back and let you know what I learned, even if I don't have a solution yet. And then we're going to work and I'm going to figure out, this next step to take. And let's now try this together. And then you're going to let me know how it's working for you. And so that's how I think about that. Next slide, please. And then finally, around discharging and leaving the hospital, don't hesitate to request an alternative format for discharge instructions. So maybe it's simpler, larger font, in a like an electronic format that's important for you. I think one of the differences during this time is that in the past, hospitals would have caretakers like come into the hospital, have a formal meeting with the patient and the whomever is helping to support the patient outside the hospital. And some of that is not happening now, and may be happening just over the phone, and may even be happening separately, between the person and their caregiver. So don't hesitate to request either an in-person, if it's like a support person that can be helpful, or a virtual meeting that includes you and whomever your support person is, so that the education and instructions can be presented to both of you at the same time, so that everybody is on the same page together, both around what's communicated and the information that's received. And then finally, we just wanted to share that hospitals typically send surveys to people's homes after visits, and the hospitals really use that feedback to guide practice and improve, quality of different things. It's very important to them. And so I just wanted to share that, I'm sure can be like a very stressful time, but if you have the ability and the energy to complete a hospital survey and send it back, the feedback that is accepted on, or the feedback that you provide, is just so highly utilized. And I think it's something that I really wasn't aware of until I worked in the position that I'm in, just how influential that can be in creating change at a hospital. So just wanted to encourage people to do that. You can forward the slide. This is the reference for the article that Sarah was mentioning earlier. And then if you can move on to the next slide. And this is the link to JACO for more about the standards around patient-centered communication at hospitals. And you can forward the slide. Okay, and then we'll stop here for questions. And if you want, we can end the slide view and come back to everyone. I know we went a little longer than half an hour. It was a lot of information. But I know we have plenty of time left together to answer questions.
Well, thank you, Karen. That was wow, so much to think about in terms of detailing the kind of specifics that any of us might need to customize for our own hospital planning. Wow. So this is a time where we can have a good discussion. You can use chat to post your questions, or you can raise your hand in the participant list. And Megan, how does one raise their hand in this list? You don't see that icon here.
Sorry, June, I was away from my mute button. So you should be able to raise your hand if you go to participants. It'll pull up under there's a little 3 dots button, and there should be an option to raise your hand there, or you can do Alt-Y. That should work as well to raise your hand. So the Alt key and the Y key together.
Okay, we'll Megan and I will keep an eye on hand raising there in chat per that list, or again, your questions in chat are welcome.
I did see someone write, can you highlight something on the discharge plan from the hospital to the community? I'm happy to give some examples, and then you can let me know if that answers your questions. So it would be follow-up appointments that you have. It would be any symptoms that would be important to be looking out for that would indicate you need to return to the hospital. It would outline what you were diagnosed with, you know, any testing, the medications that you'll be taking when you go home, and the instructions for those. So sometimes discharge paperwork can be quite lengthy. And have, you know, as you can imagine, all those kind of different components included. Does that answer your question? Oh, if anybody is getting discharged for community placement with disabilities precautions. Do you mean a placement as in back to a previous living situation, or do you mean a placement as in going to a rehabilitation facility? A new place in the community. Okay, and it sounds like your question, by disability precautions, do you mean information about the accommodations that you benefit from? Or that you need, not benefit from, but that you need and require, and kind of trying to look for help with advocating for that? No specific measures. Specific measures taken to keep individuals with disabilities safe. The discharge paperwork would have anything that would be a medical precaution to keep someone safe. So, you know, it might be positioning of a certain kind, like, you know, should not lay flat, or like it could be like, let's say someone was admitted with a broken leg and had surgery, and now they're not allowed to put any weight on that leg. It would give what the precautions are and for how long. Those are the kinds of precautions that would be in a discharge summary from a hospital. Anything that would be medically related to that stay.
I see a hand raised from Fidel Medina. Do you want to unmute yourself?
Thank you. Thank you. Yes, this is regarding interpreters. I wonder, in the larger hospitals where you three ladies work, we have a UC center here, and we have Kaisers that are pretty big. This is on the West Coast in California. And one of the things I've been asked from my consumers is it appropriate, and not trying to be rude, to request an interpreter for physicians that you cannot understand? For instance, I was once told that a physician was talking to this patient, and the patient requested an interpreter. And the nurse said, "Well, you speak English really well." And the patient said to the nurse, "No, it's not for me, it's for the doctor." And I think it was an important thing. Maybe I wouldn't have asked for it that way, but it's important that, because these medical centers are teaching hospitals, and there is a lot of those situations that doctors are very busy. Maybe they're not understanding what the patient's saying, but more important, the patient doesn't understand. So if the language of choice for a physician is whatever language they speak, then could the patient ask for an interpreter from that physician's language to English? Over.
I think so, because I think when our interpreter, and you two should jump in after me too. When our interpreter services here at MGH are really awesome, and they come and they do presentations to our departments, and they say, if you need the interpreter for, not just like to make sure you're communicating to the patient, but let's say the patient says, oh no, I don't need an interpreter. I got this. I can understand fine, but I would feel more comfortable having an interpreter there with me, also speaking, the second language or the first language of the other individual. I can request that they come there for me. Did that make sense? I didn't say that in the most eloquent way, but and I think about that as the opposite should also be true, that just like I can have an interpreter there to make sure that my communication is being understood by the person at a level that I feel comfortable with, even if the person who is being interpreted to says I don't need someone, then I don't see why the tables couldn't be turned too. That a person could say I like an interpreter just because I feel like there are some communication barriers, even though we both speak English, and I think it would be helpful, to try it. So that's an excellent question.
And the level of communication is very important in healthcare. Yes. Sometimes the doctor may be speaking about something and the patient is not, and it has nothing to do with medical terminology or anything. Right. It's just based on what the importance of something is. There may not be any fluctuations in the voices because of the language that they normally speak. Yes. You wouldn't say it the same way. So thank you very much.
Oh, you're so welcome. I think that brings up how language has a cultural element to it too. It's not just a direct kind of, part of what medical interpreters do isn't just help make sure exactly what's said is said, but also help to keep in mind the culture aspect as well, and make sure that that is fully understood. So thank you. That's a great question. I don't know if Rachel or Sarah would want to add anything to what I said.
No, that was a great explanation. My only caution would be to just make sure that doctor does actually speak that other language and doesn't have a strong accent. That person may not any longer be fluent in the language that you might anticipate that they speak. And so it's a tricky, I've never had that question come up either. And it's a tricky situation, but I think being open and honest with the doctor that you're not understanding, and maybe asking them to rephrase or add some visuals. In addition to asking if speaking it in a different language would be more helpful or natural for them.
I might add, if you feel uncomfortable about saying that to the doctor directly, you can always speak with your nurse or the nurse manager and say just very plainly, I'm having a hard time communicating with my doctor. This is why I feel why that might be. And then that nurse or nurse manager can help you kind of navigate what could maybe be an uncomfortable conversation, might help you navigate that a little bit easier.
Rachel, while you're unmuted, did you see the question in the chat about SLP consults in the ED?
I did. So the question here is, for SLPs in inpatient roles, how does it typically work to consult in the ED? Do you get called to assist with AAC or evaluate for complex communication needs? Or what communication situations in the ED would an SLP be called on for? Or do you typically work with patients only once admitted? Okay, there's a lot there. So I can really only speak to our practice at Mass General, and a consult for a speech language pathology evaluation can happen from the moment a patient enters the emergency department. And that can be for speech, language, swallowing, voice, cognition, or AAC. Now, when, there are a lot of factors that go into whether or not that patient is seen while they're in the ED, or if they're seen when they're admitted, but we do see patients while they are in the ED. Reasons why we might see them in the ED might be this is a patient that is simply going to stay in the ED or the ED observation unit, and we need to get these questions answered or find these supports before they are returned to the facility that they came from or return home. They don't require admission, but they still want our support before they discharge them. Now, we might also go and see a person in the ED before they're actually admitted to a unit, because this is a patient who the team may really, really require some assistance. So in the case of AAC, maybe this is someone who has come into the ED and they have complex communication needs, and the nurses say, oh my gosh, I need help. We see that this patient has these needs. We're going to put in a consult for SLP. We need their assistance to kind of suss all this out. And so that could be a reason that we see that type of evaluation in the ED as well. Most of our consults are when patients are admitted, but they do happen in the emergency department. Does that answer your question? Okay, good.
I saw people mentioning earlier in the chat about having a binder that they carry with them and that being really effective. Just want to second that. I think that's a great idea. I know we talked about the wall sign a lot, but a binder, anything that I have a care plan here that I use that outlines not just what someone someone's communication needs, but also like any sensory needs they have. And then also like by different procedures, how well it's tolerated and any challenges. So does someone have difficulty with waiting? How do they do with having an IV placed? How do they do with taking medications? What kind of, supports do they need for self-care? All of those things could be things that, you document or if particularly, or that you have in a binder, particularly if there are things that are difficult in the medical setting for the individual, and if there's particular strategies that have worked before. I have one young woman who needs, 3 people who work with her all the time in order to tolerate having an IV placed awake, but they have this system down with her with now where she's tolerating it great as long as she has them. So kind of outlining some of those things unique to people is helpful.
And if I could jump in, I think as a healthcare professional, I actually second the frustration of not always being able to get records that you would love to be able to see. I think it would be a wonderful world if we could with of course signed consent, we could access medical records from other facilities. Sometimes we have patients who come in and it's reported to us that they've been seen at X hospital or has been seen by a speech pathologist at, this location. And boy, oh boy, would we love to see their notes, and it would really help us. It would be a good jumping off point. But sometimes it's not that easy. And that's a frustration, honestly, on our part too. So what a world we would live in if we could make that easier.
I wanted to jump in here. This is June. I was thinking a lot about the comment about bringing your own notebook. And it's parallel to your advice about putting things on a flash drive. My experience with healthcare in more recently is getting them to put any kind of thumb drive in any of their computers is not acceptable these days because of caution related to all kinds of hacking, viruses, etc. So I think the notebook, even though it's a throwback to, killing more trees, might be more resilient these days than the thumb drive. Something to think about that hadn't occurred to me till I've been listening to this discussion.
At our hospital, when people bring in hard paper records, typically there's someone on the unit who can scan those in to what we call a media portion of the medical record. And that way, at least they are in the medical record and they can be easily accessed that way.
The other thing I wanted you to, I thought Fidel's question was very important. I've been in a position where I've had to interpret for somebody who's has a hearing loss because they can't understand the person's accent, even though they're speaking English. And so I think I don't know, in urban settings, at least here in LA, the diversity of the healthcare staff is awesomely broad. And so understanding all these accents, I think for some people is a difficult task. So I really thought that question was critically important. And I think it's also resonates for people with, again, hearing loss to begin with. So
Especially when you add masks to the mix too, so that now we've lost the visual cues of someone's mouth moving too, that was likely very supportive, prior to. I can understand.
I think I had actually seen much further up in the chat while the presentation was happening, someone mentioned like a text to speech or a speech to sort of an app. And there are apps out there. I think one is called Ava that can where someone is speaking and then the app sort of puts that into speech on the phone or on an iPad. And that way you can see exactly the speech that's coming across the screen. Sometimes we use those for maybe our newly hearing impaired patients or people who are very savvy with their phones and tablets and they use them very easily.
I wanted to clarify and go back. I see a couple comments about that hospitalist. One of you mentioned the importance of really checking in with that one person maybe once a day. And I know down here and my primary care doctor once said, I can't go to the hospital anymore. It's just too much to make early morning rounds. So I'm working with a hospitalist and just be aware of what they do. They are my communicator and they're communicating with me all day long. I don't know how common they are or whether how helpful this is to consider as the person, but just wanted to know what your experience is with that label staff kind of person these days.
So at our hospital or at MGH, I agree that I think if you can get a physician or a specialist that sees you in the community, but that also has hospital privileges, that can be helpful to you when you're inpatient, because even if that person doesn't end up as part of the team caring for you, if they're there in the hospital, they may come to see you, which is very nice, or they may, be able to help communicate with your team on your behalf, as you said, June. We do here at MGH, and I don't know what they have at other hospitals, but we have a service called the Complex Care Team, which cares for some of our most medically complex patients, and they serve, some of them serve as both the patient's primary care physician and their hospitalist, they're attending, their lead doctor, when they are needing to be in the hospital inpatient. And so, of course, that kind of care model is it's wonderful, because then you have, the person taking care of you while you're in the hospital also understands all the little details around your medical care, kind of when you're in and out. I don't know about that model in other parts of the US, but just to know that those things, those kinds of models do exist. And, it is, I think if you are someone who has frequent hospitalizations anyway, it could very high, and by frequent, I mean, more than like 3 times a year, even like somebody with like 5, 6, 8 hospitalizations a year, it would likely highly benefit you to have, you know, to try to get a physician who works at your hospital inpatient that could also be your primary care or a specialist involved in your care in some way too. You know, I don't know if, does that answer your question, June?
Yes,
Okay.
I think so. Good.
I wish it was available for anybody who wanted and needed it. That's like the heartbreaking thing, you know, that even for patients who are here or MGH patients, it's still a limited service, you know. But anyway, as far as
I don't see any hands raised in the list. So did any of you want to add issues that you didn't get to touch upon? Including you three speakers, panelists?
I think I see a follow-up question to earlier about what do people do when there's when they don't have any supports in the community. It's such a great question. As far as discharge and follow up at discharge of somebody who was maybe inpatient following up outpatient, you know, I can speak to, we do have a program here with what's called an attending nurse, where the attending nurse makes follow-up calls, but it's usually just 1 or 2, and the goal is really to just check on the person because and to hopefully avoid a readmission. You know, hopefully the person has what they need, everything worked out smoothly for them, because when a readmission is going to happen, it usually can happen quite quickly. And so that is that role of the attending nurse. But as far as someone who's inpatient, continuing to follow someone outpatient, I don't know. It's not a practice that we have here. You know, I think as far as supports in the community, I hope that at the very least, you have a primary care physician. I know that supports through those offices can be very limited. You know, I've found, or families, and actually, and I think what's wonderful is to be a part of a community like everyone that's here today, because it's really, in my role, I've learned so much from families and individuals who are parts of systems, who have gone through experiences themselves and have ideas around resources that are in the community. You know, there are kind of state organizations, like, so for example, we have the Department of Mental Health here in Massachusetts. We have Department of DDS, like developmental disabilities. I'm sure, you know, each state has varying kinds of departments like that. That can always be a place to begin, or even your own local, you know, community health center. And what's great is if you have virtual access. I mean, I think that's one of the most exciting things that I feel like I'm seeing is with telehealth. As long as you can access the internet and you have what you know, or you have a phone, that the access through telehealth is just so very different and broadened. You know, there's likely things that I'm there's actually many things I'm not aware of, but that you could likely access even just through telehealth. So just, you know, wanting to encourage you to keep looking around, keep asking, and especially now that telehealth is so much more prevalent.
Can you all go back and talk a little more about the call button? A lot of people I know over the years have kind of complained about lack of access to them or them not being able to activate it. And the hospital not always have the kind of technology backup to give them something that works, like a big button or whatever. What's the best way to advocate for call systems that you can use when you're not able to use the most common one?
Oh, go ahead, Rachel.
Oh, no, please, please.
And please jump in, but most hospitals do have alternative nurse call options. And as Rachel was talking about earlier, it is a joint commission requirement that you're able to signal help and get the attention of somebody in your room. And so there are a variety of alternative nurse call options. There's something called like a soft touch. It's a big type of plate that you can touch. It doesn't require a lot of force. There's some squeeze balls. There's some you might be able to activate by like blowing into. There's some that respond to like a click or a small muscle movement. And some are more specialized than others, but and I don't know obviously what every hospital has, and that's why it's helpful to call ahead of time and ask. But I would imagine that many at least have some pretty widely used generic alternative nurse calls. And I think it's really the best way to go about that is just to ask. If you anticipate you're not going to be able to press that small button on the remote control, it's definitely something to be proactive about. And we can put some links in the chat to some nurse call options too.
And I would add that two services that can be very helpful in troubleshooting that kind of scenario are speech therapy and occupational therapy. So oftentimes when we're trying to find what is the best call button option for a patient, speech and OT work really closely together because we're sort of looking at we're each looking at the different abilities of the patient and okay, what is going to work best for you, and then collaborate with nursing to also try to find you the best option. So those are two services you could advocate for, asking for a consultation.
You can also find out, like for your hospital, what I don't know what to call it, but because it's like a technical thing. But for example, like, or not even technical, but for example, here at MGH, where you plug the call bell in is actually a universal kind of plug, like a little jack. You can even go pick it up at Radio Shack. Well, used to. I don't think Radio Shack's around anymore, but like, you know, it's that sort of thing. And so I think if you are someone who would need a specific kind of setup for adaptive call bell, you have frequent hospitalizations, it may not be that expensive of a setup for you to bring your own too, and find out like if your hospital has like what kind of universal kind of plug-in. You know, it's always worth exploring kind of outside the box too. And again, like thinking that proactively, like how could be addressed before you even get there, so that then you don't go 48 hours without ability to use a call bell, you know, while consults are being put in and then people are prioritizing and then you're getting seen and evaluated and then we're going to go find the equipment and we'll be back and all the rest of it. So I think just to kind of throw that out there too is a good, something good to, if you want to problem solve outside the hospital too. I saw the question from Bruce Morgan about the one of the problems with our consumers is many have no family or people that can go with them to a procedure. For some procedures like a colonoscopy, the hospital will not perform the procedure unless you have a person with you to drive you home. Even they will not accept Uber or a taxi ride. You're right. And how would you suggest a consumer deal with this situation? I'm kicking myself right now because I feel like my brain has a better answer for this and it's not coming to me. But I think I know that this is an issue, and this is an issue for things getting canceled and then people not having access. And what I would suggest is go to whomever is ordering the test. So for example, if it's your primary care physician or gastroenterologist that's ordering the colonoscopy, go back to that person and say, I want to do this, but I don't have a support to be able to come with me. You know, how, please help me figure out how to remove that barrier, because it's true. You know, unless you have the financial resources to like briefly hire someone temporarily, you know, but what I don't know is like, would case management, for example, be able to arrange for, it's not an ambulance, but it's like a different kind of transportation, like a medically safe transportation home with then a VNA in place to check on you that evening. Like I'm thinking that there are ways to move around that, but I would involve the ordering provider. Yes. So yes. Oh, good. I was on the right track. There's a comment, ask your PCP to order home health nurse for short-term assist. Yeah. Yes. People with very little income, I completely understand. Yes.
Okay, well, we're almost out of time, but I really wanted to thank you all for a great and very detailed discussion. Lots to think about here for, you know, typical times and for COVID times. So a lot of things we need to consider in terms of our own planning. Thank you for helping us to think about this much more broadly than maybe some of us have in the past. Just a reminder that this topic call is recorded and it will be posted on the Disability and Disaster website, and it'll be up in a few days along with the slides and other suggested resources that were also distributed. So again, thank you to the three of you for your very impressive presentation and preparation and slides. It's most appreciated, particularly for the three of you who view things from the inside. Really a big thank you to the three of you. And thanks for the rest of you for joining today. And we'll talk. We have another call at the end of the month, the fourth Thursday, a more of a advocacy call where we'll probably continue some of these issues in that discussion as well. So thanks again, and talk next time.
Thank you, everybody.
Bye. Thank you so much for having us, June.
Yes, good job. Really.
Thank you. Thank you so much.
Bye.
Take care, everyone. You're welcome. Take care.
Thanks again. Bye-bye.